And good morning, everyone. Today, my topic dermatology for day to day practice. So, I thought of talking about eczema because eczema is the commonest dermatological condition worldwide. So, all the doctors should know a bit about eczema. So, eczema or dermatitis, both the same. There are exogenous eczemas like contact dermatitis, may be allergic or irritant, and also due to photoreaction. And endogenous causes, atopic dermatitis, seborrheic dermatitis, discoid eczema, and venous eczema is very common, and also pompholyps involving hands and feet. And there are some unclassified eczemas, steatotic eczema, lichen simplex chronicus, and juvenile plantar dermatosis. So this is how it looks like. Atopic dermatitis is common in children, and also in some daily extend into the adulthood as well. Involvement of the cheeks and flexural involvement is very common in atopic dermatitis. And then the seborrheic dermatitis, the nasolabial fold involvement and involvement of hairy areas like eyebrows and scalp involvement is common, and also the flexures are involved. Photoreaction, the photodermatitis, the lesions are commonly seen over male areas of the photo, mainly the photoexposed areas. Then discoid eczemas, plaque-like lesions, commonly seen in limbs, and also the pompholyps, blisters appearing over hands and feet. And some more, steatotic dermatitis, commonly seen in patients with hypothyroidism, as well as patients on certain treatments like diuretics and elderly, and the patients with frequent habit of frequent washing. Next, the lichen simplex chronicus. It's kind of a neurodermatitis, a severe itchy condition, and juvenile plantar dermatosis. So these are different forms of eczema. Okay, whatever the cause is, treatment is much more similar, and there are some instances that changes, but basically the same principles in management. All the patients with eczema, we have to consider about barrier protection and repair. So regular baths and lot of emollient usage helps a lot. And then to reduce the inflammation, again emollients play a major role. Then topical treatments like steroids, the mainstay of treatment, and calcineurin inhibitors, tacrolimus and pimecrolimus, they are widely used to treat eczemas. We also use phototherapy, narrowband UVB, as well as Sorolin plus UVA treatment to treat severe forms of eczemas. And then the systemic treatment, azathioprine, cyclosporin, methotrexate, these immune suppressive agents are widely used. Also, eczema is very itchy condition, so we need to attend to the pruritus. Patients need antipruritic agents. And also, how much ever you treat, you have to advise them on avoiding trigger factors, otherwise the recurrence is common and exacerbations are common. So when there are acute flares, you have to treat accordingly. In acute flares, they get eczemas, they get oozy weeping lesions, so need astringent medication like potassium permanganate soaps. And when patients are having acute flares, we always use steroids as creams or lotions, and always ointments are avoided. And we have to treat the cause of acute flare as well, because the commonest cause for acute flares are infections, staphylococcus aureus or herpes simplex infections. They are the commonest causes for acute flares. And also, one more important thing, you have to educate the patient well, because this is a chronic condition. You need very good compliance. So patient education is a must. Okay, so next I thought of moving on to dermatophyte infections. So during the last 3 months, I went through my clinic records and I found that 9.5% of my new patients are having some sort of dermatophyte infection. So this 9.5 out of all my patients, that is a very high percentage, and this is becoming commoner. So we should know how to treat dermatophyte infections well. Dermatophyte infection, so dermatophyte is a keratinophilic fungus. It's the commonest superficial fungal skin infection. Although it's not associated with severe complications, there are significant psychosocial impact and decrease in quality of life. So proper treatment is needed. In dermatology, we have fancy names for everything. So according to the site involved, there are different names: tinea corporis on body, tinea faciae on the face, and tinea cruris involving flexural areas, especially groins and axilla. And then the nail involvement, tinea unguum or onychomycosis. And then on scalp, there's tinea capitis with less inflammation. And this inflammatory boggy mass, which is often mistaken for abscess, this chirion. This is commonly seen in children. And some more, tinea pedis on feet and tinea manum on hand. Okay, so when it comes to treatment, this is a fungal infection, and obviously the treatment is antifungal agents. There are topical antifungal agents and oral antifungal agents. The commonly used topicals are azoles like clotrimazole, miconazole, and ketoconazole, and also there are amorolfine and cyclopyroxazolamide. And antifungal agents, the standard treatment, itraconazole 100 mg twice daily dose, and mind you, this is minimum of 3 weeks. So the tinea infections should not be treated less than this much of a period. So you have to treat for a longer period. And if you are treating with terbinafine, it has to be 250 mg daily for at least 4 weeks treatment. And this griseofulvin and fluconazole were used over the years, and now the minimum inhibitory concentration is reaching a higher level, so that's showing very less response. So this is the dose for griseofulvin, and fluconazole should not be used, and that's only used in some special situations, so that is 50 to 100 mg per day dose. And always it's strongly discouraged to using weekly doses of fluconazole. Over the years, dermatologists in Sri Lanka has noticed that there's lack of response to the conventional antifungal agents that we used and their doses. So the possible reasons for this are virulent pathogenic species, and when we were registrars, Trichophyton rubrum was the commonest organism that caused dermatophyte infection, and it has changed to tinea mentogophrys over the years. And recently, tinea indotinea was identified in India, and now it's being the commonest organism in India. And few weeks ago in MRI, they isolated tinea indotinea. This causes disease which is resistant to treatment. And also host immunity factors affect for this recurrent recalcitrant dermatophysosis, and also the drug resistance and some environmental factors. So when it comes to host immunity, one factor that affects mainly is the use of topical steroids. Steroids modify the tinea. This is how it looks like, steroid modified tinea. So we call this tinea incognito. The classical margins are lost and less inflammation and hypopigmentation due to steroid use. Although the inflammation is less, the organism keep on growing. So that causes recalcitrant disease. And all these photos are of tinea incognito. So to further understand these causes for recalcitrant disease, a group of dermatologists designed a study involving all 9 provinces of Sri Lanka, and this was published in American Journal of Tropical Medicine. And interestingly, your hospital is also included in this study. So they included nearly 800 patients having dermatophyte infection, and in their they studied that out of these patients, 58% of the patients were previously treated with steroid when they came to the clinic. So 58% is a very high number. Now they further analyzed the data, and they treated all the patients with the traditional standard antifungal treatment, and at the end of 10th week they assessed the response. And among the group, that the patient group who were not treated with steroids, at the end of 10 weeks, most of them had complete response, and only very little of them had partial response. And in contrast to that, the patient who has used steroids before, the complete response group was less, and in contrast to this, more patients had partial response. And this was statistically significant. And further, they followed up these patients for 3 months, and among the complete responders, the recurrence rate was assessed. So patients who did not use steroids before had less recurrence, and the patients who used steroids had more recurrence. So again, this was statistically significant. And now we know, if you use steroid creams in patients with dermatophyte infections that make chronic disease, which is less responding to treatment, and also among the responders, the recurrence rate is high. So steroids should not be used in dermatophyte infections. And they further investigated the sources of topical steroids. Surprisingly, the most common source of topical steroid was outpatient departments of government hospitals, and GPs contributed to more or less a similar amount. These are the culprits: triple combinations having steroids, antifungals, and antibiotics. So this should not be used. And during the recent past, Sri Lanka College of Dermatologists, with the leadership of Dr. Mrs. Udagedara, was able to convince NMRA to cancel the registration of these triple combinations. But unfortunately, they are still widely available in the market. They come through baggages. But it's not anymore licensed in Sri Lanka. Okay, so what's our responsibility? So confidently diagnose the tinea infection, and be smart when you treat the patients. Treat them with a proper drug for proper duration. And also don't forget to follow them up and see whether there's complete response, whether there's recurrence, and whether there's any side effects of drugs. Okay, next I thought of talking something about acne. So acne is a chronic inflammation of pilosebaceous units. Comedones may be open or closed, then papules, pustules, nodules, cysts, and scars. So there are different varieties. The common group having acne is teens and young adults. Most commonly the face is affected, and also shoulders, back, and upper chest are affected. So these young adults having lesion on face, so this has a significant impact on their psychosocial well-being, and this is why it should be treated. When we talk about the pathogenesis, there are 4 main things: the pilosebaceous duct hyperkeratosis, and then colonization with Propionibacterium acne, release of inflammatory mediators, and increased sebum secretion. So these things brings the inflammation. And what are the aggravating factors? Androgenic hormones, may be endogenous or exogenous, and drugs, again the steroids, hormones, anticonvulsants like phenytoins, and there's a long list of drugs. And there's familial tendency in acne as well. Also, patients with polycystic ovarian disease have more chance of getting acne. Nowadays, there's a very big problem with these occlusive cosmetics. They cause acne on face. High environmental humidity, and also high glycemic food, and also diet high in dairy products. There's very weak association, but it's said in literature. So this is how the patients presents, from mild acne to moderate acne and then severe acne. In mild acne, there are very few lesions, less inflammation, mostly comedones. When it comes to moderate acne, more inflammation, more redness on face, and more papules. And later, the severe acne, there's papules, pustules, nodules, cysts, and everything. Some special varieties, nodular cystic acne, and also acne excoriae. This is common among young girls who keep on picking acne, and also the patients with psychological patients who are affected psychologically, they get acne excoriae. And why should we treat acne at a very early stage? It is to stop this kind of unacceptable scars. So nobody would like to have scars like this. The treatment options, there are topical treatment and systemic treatment, and also physical treatment modalities. The topical treatments include retinoids. There are different classes of retinoids, from tretinoin to adapalene. Benzyl peroxides are widely used. Antibiotics, especially clindamycin and erythromycins, are used as topical treatment. Acylic acids and nicotinamide also help. Systemic treatment, antibiotics, the commonest used one is doxycycline. Also minocycline, limecycline, the newer drugs also are helpful. Azithromycin is also used to treat acne. So when you treat systemically with antibiotics, it's not just 7 days of antibiotics like in other conditions. This has to be a bit prolonged period. Usually some patients need antibiotic treatment like 2 months, 3 months, and some even more than that. So 1 week of doxycycline treatment would not do anything to heal acne. Anti-androgens are used, cyproterone with ethinyl estradiol and spironolactone, and the last option is retinoid orally. Some physical treatments that helps include laser, cryotherapy, and intralesional steroid injections in very few occasions. Also, electrosurgery is used to remove comedones. Microdermabrasion is also used. So, when to use what drug? So, this is the algorithm. In mild acne, just topical retinoids would do. When it comes to moderate acne, we have to use oral antibiotics with topical retinoids and perhaps benzyl peroxide. Again, for nodule acne, it's oral antibiotic, topical retinoids plus or minus benzyl peroxide. For severe acne, the treatment of choice is always oral isotretinoin. So not only treating the patients, you have to, not during the acute episode, you have to use maintenance therapy as well. For that, topical retinoid is the best. And sometimes in severe cases, benzyl peroxide is also used. There are acne scar treatment options. We commonly use chemical peels, dermabrasion, and then laser resurfacing is quite often done. And also there are some other energy-based procedures using different lights. Steroid injections, especially for keloidal scars. And then skin needling, subcision, fillers, and botox. Lot of procedures for acne scar treatment. Okay, now I have been speaking about three dermatological conditions. The most common one being eczema, and we use steroid as a treatment in eczema. It's the first line treatment. And the other two conditions, dermatophyte infections and acne. So topical steroids adversely affect on these two conditions. And I thought as doctors, everyone should know about topical steroids, when to use and what steroid to use. And so I thought of talking something about topical steroids. So topical steroids have different effects on various cells in skin: anti-inflammatory effect, immunosuppressive effect, anti-proliferative, and vasoconstrictive. There's a huge list that we use topical steroids in these conditions: uh, eczema, atopic dermatitis, contact dermatitis, and in psoriasis, vitiligo, lichen planus, bullous disorders, autoimmune disorders like morphia, discoid lupus erythematosus, and in lymphomas, hair disorders, neutrophilic dermatosis. So, in lots of conditions, we use steroids. But whenever you prescribe a steroid cream, you should have an idea about the potency of the steroid that you are prescribing. So this potency depends on the specific molecule within the cream and amount that reaches the target cell and absorption through the skin, and also the formulation of the topical steroid. So this is the potency guide given by WHO. There are 7 classes of steroids. Ultra high or super potent steroids like clobetasol propionate in the top, and in the bottom the weakest one, hydrocortisone 1%. So in between there are lots of steroids. And also, if you notice here, this betamethasone dipropionate as ointment, it's in class 2, whereas the cream betamethasone dipropionate is in class 3, and the lotion comes in class 5. So the same compound, when the formulation is different, again the potency differs. To make this a bit easier, less complex, we'll look at this. There are very potent or super potent one, the commonly used clobetasol propionate, and potent ones, the betamethasone valerate and mometasone. Then the moderate ones like clobetasone, and mild one, hydrocortisone. So if you consider the potency of each group, these moderate potent ones are 2 to 25 times as potent as hydrocortisone. And the betamethasone valerate group, that is 100 to 150 times potent as hydrocortisone. And the super potent clobetasol is up to 600 times potent as the hydrocortisone. So although it's 7 groups, it's 600 times more potent than the weakest steroid cream. So these are the factors to consider when deciding the correct steroid to use. The golden rule of using steroid is always use the weakest possible steroid that would do the job. So it depends on side of the body. Face and flexures where you have thin skin, you have to use the least potent steroids like hydrocortisone. And for the body, you can use moderate potent ones. And palms and soles and scalp, they have very high thick skin, so you can use more potent one for these areas. And age of the patient. For infants, they have very thin skin, so it's always again the weakest steroid creams. And not very uncommonly, we come across instances where clobetasol is used even in infants. So always keep in mind it's the least potent steroid cream that should be used in infants. Then the characteristic of the lesions. There are very thick lesions where you have to use potent ones, and for thin lesions it's always less potent ones. Again, the total area to be treated has to be kept in mind. If you apply steroids over a large area, the amount absorbed is high, so systemic absorption is high and might cause systemic side effects. Again, the duration of treatment matters. If you keep on applying steroid for a longer duration, the cumulative dose absorbed is high. Then the formulation of the steroid, as I said, there are different forms, and uh, creams and lotions are used in general purpose, the most popular forms. Ointments can be used for dry and non-hairy skin. They don't contain preservatives, so less chance of getting allergies. But because ointments are very occlusive, risk of folliculitis and sweat rash is high. Gel or solutions can be used for hair-bearing skin, and then we have steroid impregnated tapes also. Why we should use steroids this much cautiously? It has side effects, systemic side effects when absorbed systemically, as well as cutaneous side effects. So these are some of the cutaneous side effects that we come across. The first one, the lady has applied some fairness cream which contains steroids, and she has got acne as well as hypopigmentation on her face. The next one with erythema and telangiectasia, enlargement of small vessels. And striae is not uncommon, especially on flexural areas. These steroid-induced striae is different from physiological striae. They are more red in color and more broader. Hirsutism again is not uncommon. Easy bruising. We commonly see this in elderly skin. With prolonged use of steroid, they get easy bruising. And when you use high potent steroids on thin skin, this is what happens. Periorificial dermatitis. Patients get multiple papules around mouth and other orifices as well. So this is perioral dermatitis. And now you know these steroids aggravate or mask skin infections. This is tinea incognito, and also they aggravate pityriasis versicolor, the Malassezia infection, and also HSV infection. So this now you know we have to always have an idea whenever you prescribe a topical steroid cream. You have to know where to apply and what the potency is to prevent all these side effects. So thank you, and this is the end of my presentation, and but I have a quiz ready for you. Uh, Price, where to get that thing? We make it here it is.
So they scan the QR code, they can access it.
Yeah, yeah.
But you need to enlarge the QR code.
Make open Karagan.
So QR code will be put up on the screen and Shall I bring the
To do it with your
if you all are in your WhatsApp groups, question, we have uploaded it into our website groups. So you can access my WhatsApp group as well. Machine is done. You can QR code. And our sponsor has kindly located two prices also for this. Is your laptop on?
make it.
Now
Make on. पद्मनाभ त्यांनी झाले So this is the QR code. You can scan this and log into the Google form. I'll give you a few minutes to sign in.
Okay, everyone able to scan it? What you could as soon as you scan it, you will be able to
Are you all ready?
you are looking for time or shall I start? Yes.
Right? Sorry? So aren't they ready with that now? So have you all signed in?
All have to fill the name and contact number of you can start up.
So sign in with your name, contact number.
How is that?
Sorry, the Nishwan.
Anybody needing more time?
Or madam, la sundan naging Haridas. Har-
Logging to their Google account, right?
oh,
So most of them
have locked in. So number one, what is the diagnosis? Right? Number two, again, what's the diagnosis? Number 3, how would you treat this condition? Number 4, what are the papules on cheeks? What is the diagnosis? Number 5. Number 6, what is the diagnosis? Number 7, again, what is the diagnosis? Number 8, asymptomatic lesion on forearm. What is the diagnosis? Number 9. What is the diagnosis? How would you treat this patient? Number 10. Number 11. This non-Nichi lesion for 8 months duration. What is the diagnosis? Number 12. What is the diagnosis? Number 13. Number 14. The scalp lesion. What is the diagnosis? Last one. 38-year-old lady with generalized blisters. What is the diagnosis?
soon as you finish answering this one, please press the submit button. When Dr. Rajesh will call your answer and please press the submit button as soon as you finish answering. So, seven people are submitted already.
So if you have finished by now, please submit it. Sorry? Okay. So if you have if you have finished answering the questions, please press the submit button. Okay, so until Rice gives us the results, we'll see the answers. Make can you Padmala මේකේ මුලට ගිහින් දෙන්නකෝ. Oh, yeah. Computer start කරන්න. මේක this.
Okay, now you can check your email if you are going there. And
අයියෝ. Open in.
we do have the winners. Winners are there.
Okay. Answers ටික කියලා ඉන්නද? හරි. So let's see. මම 3 ඇස්ති කරලා දෙන 2 තමයි දෙන්නේ. Patman? Okay. So what is the diagnosis here? Pityriasis rosea. You see the herald patch, the large mother patch down with a collarette of scale, and the daughter lesions here, papules and plaques with erythema. What is the diagnosis here? This is toxic epidermal necrolysis. So when the body surface area involvement is less than 10, we call this Stevens-Johnson, and 10 to 30% involvement, we call it SJS 10 overlap, and when more than 30%, it's toxic epidermal necrolysis. So what is this condition? It's a candidiasis, common in neck, especially when kids are wearing that kalu noola with panchayuda. So this is very commonly seen. Candidiasis treatment is miconazole cream, local application. The papules on cheek, angiofibromas, you see this in tuberous sclerosis. There's another clue on the forehead. The forehead plaque is also there. Diagnosis here, granuloma annulare. In tinea corporis, there's more scaling and epidermal changes, whereas granuloma annulare, it's a dermal condition, very less epidermal changes. Easy one. Diagnosis here, molluscum contagiosum. You see the dome-shaped pearly pink papules with umbilication centrally, caused by pox virus. Diagnosis here, psoriasis. This is a patient with guttate psoriasis. You see the salmon pink color small plaques and papules with silvery scales. Lichen planus is more seen in limbs than the trunk, less common in trunk. This one, cutaneous leishmaniasis, indurated plaque with surrounding hypopigmentation on exposed areas due to sandfly bite. So, cutaneous leishmaniasis. Uh, Number 9, pyoderma gangrenosum, ulcers with a violaceous border and undermined edges, commonly seen with inflammatory bowel diseases, autoimmune diseases like rheumatoid arthritis, and also some hematological malignancies. This one, herpes zoster, involving the mandibular division of trigeminal nerve, the dermatomal pattern. So the treatment is with oral acyclovir. Again, this is a patient with leprosy. In eczema, you get itching and also scaling, and 8 months is a bit longer period, so this is in leprosy. Bullous papular urticaria, common in children in exposed areas. Bullous impetigo, you get very flaccid blisters. In contrast, here you get very tense blisters. Acute zinc deficiency, acrodermatitis enteropathica in children, you see this at the period of starting weaning food. A differential diagnosis is infantile seborrheic dermatitis, but here you see this characteristic border with this color because of skin necrosis. Alopecia areata with minimal epidermal changes, so smooth patch of alopecia, and this condition does not affect the gray hair, so the gray hair remains in the center, and at the periphery you see some small hair which we call the exclamation mark like hair. Alopecia areata. In tinea capitis, there's a lot of scaling and inflammation. Last one, this is pemphigus vulgaris, common in middle age and affecting the central area of the body mainly, and bullous pemphigoid that affects the peripheries and also older people. So that's the end of the quiz, and I would the secretary would announce the winners of the quiz.
So for the runner prize, I would like to call upon Dr. Vishwardhana to hand over the prize, and it goes to Dr. P. Dhanush. Dr. B. Dhanush.
So Dr. P. Dhanushan must be an online participant, so you will receive your prize from KSM in future. The winner?
Winner is Dr. Himali Sen,
Dr. Himali Senaviratna.